So thank you very much, Andrew, for joining us again. We last talked in April, and at that time we were talking about some of the cuts that were proposed to SAMHSA and HRSA and other programs. Since that time, a lot has happened. And also since that time, we might have learned new things and come to discover that some of the most extreme cuts that were proposed perhaps may not come to pass. Others may. We also know that there are real world implications of even the proposed cuts. And while we may not touch on Medicaid per se, it's related, to providers, and the proposed, and I guess the past cuts, to Medicaid as part of the big beautiful bill, are already having impacts because of uncertainty and the inability to plan or budget. Programs are curtailing, they're closing, and many treatment providers and ancillary services are being affected nationwide. So maybe it makes sense to what has happened since April. What have we learned, and kind of where are we?
Right. Well, I think a good place to start, Chris, and thanks for having me back. I think a good place to start is with the reconciliation bill, whatever it's been dubbed in the press or whatever its legal title is. Here in DC, we call it reconciliation, and this is the bill that had to do with the cuts in the budget in order to implement Trump's policies, which is a very common tactic used by a new president who has control of both houses of Congress. President Biden did it. President Bush did it. President Clinton did it. It's a very common tactic. As we know, and as you led off with, the savings were found for the most part through cuts to the Medicaid program. So I'll try and keep it as simple as possible. This bill has passed and has been signed by the president, and the impact on Medicaid in reality, or at least on paper, remains to be seen, because some of the changes won't take place until 2026 or 27 or even 28. And as a result, opportunities remain to still tinker with the bill, or with the changes made by the bill. Let's talk about the impact on the Medicaid population and the SUD consumer and treatment populations. The main aspect of the cuts was, you have to understand, there were no cuts in terms of this specific benefit or this specific, rate. Those were not changed. No, there was nothing that said disease A is not covered, disease B is covered, this condition, that condition, nothing like that. The major changes were in eligibility. Who can enroll in Medicaid? So let's talk about those changes first. The population that will see the biggest impact is what we call the expansion population. People who are able to now receive Medicaid benefits as a result of the Affordable Care Act. The Affordable Care Act extended Medicaid eligibility from anyone who was or any family or household that was at 100% of the poverty level to 133% of the poverty level. It's that population that's now eligible that will be susceptible to these new guidelines. What are these new guidelines? The one everyone talks about the most is work requirements. And without getting into the dotted I's and crossed T's, if you are a member of the expansion population, you will have to either be employed or seeking employment or engaged in community activity, so on and so forth, in order to maintain your benefits. An incredibly high percentage of the Medicaid population is already employed. It's in the 90s. I'm not sure what the exact percentage is, but it's in the 90s. Then we have the question of when these work requirements will take effect. That's up to the states. Some states want to implement them very quickly. Some states already have some work requirements. Other states want to push it off, and they have, I believe, until the end of 27 to push it off. Either way, states are going to have to start preparing for these changes. Then what we also see is, how will this impact the SUD population? And that also remains to be seen, because there are exceptions to this work requirement. For example, as is usually the case in Medicaid policy. If you are considered quote unquote medically frail, you are exempt from these requirements. What is medically frail? That is up to the secretary for the most part. As I tell your viewers, when the bill is signed by the president, that's not it. For some of us, that's only like the halfway mark of the process. Then there's rulemaking. The bill is actually very vague when you think about it, because there are still areas where you say, what does that mean? The secretary and others, as defined in the bill, will start to set guidelines for what exactly this bill means. The question becomes, are the population you and I serve, the SUD consumer population, will they be defined as medically frail and therefore exempt from these work requirements? In the past, in certain cases, they have been. So there is that possibility. It remains to be seen. We also have other eligibility requirements, such as you will be, instead of as is now, you are required to show that you are eligible to receive Medicaid once a year. You will be required to show you are eligible twice a year. This measure in paperwork alone could be costly for the government, but we're not talking about that. People are almost certainly bound to fall off the rolls, as we say. And if they do, it's not a matter as simple as, oh, my requirements lapsed. Let's pick up where we left off. That's not going to be the case. You're going to have to re-enroll.
And that was one, if I may, I mean, this is one of the more challenging aspects for people, especially people who might be experiencing, significant mental health issues. They don't have a lot of recovery resources. I mean, these are people who, hopefully they are considered medically frail, but that can be a substantial burden for people. You might not have the documents that you need. You might not know that you necessarily need to reapply. So yeah, that's a big hurdle, and I've heard some discussion in the news media about that being a big problem.
Yeah, and that's what kind of hits our population pretty hard, and you and I both know that sometimes we try to make the argument that SUD and associated disorders are quote unquote the same as any other chronic disease. In the reality, they're not. They are very time consuming, obviously, and in terms of the treatment and the recovery and the effort that's required to manage the disorder. And yeah, like you said, people who have SUD, who are going through treatment and recovery for SUD, they have a lot of challenges. In addition to looking for employment or housing, whatever, there are other benefits to apply for. There could be criminal justice obligations, such as parole. Who knows? Time is a valuable resource, and having the time to to do that, or even just having the knowledge that this is required, takes it takes quite a bit. So I just want to, so when all is said and done, at the end of the day, we've seen estimates all over the place about how many people will lose coverage. The number that seems to be in the mean or median, whatever mathematical average you use to, you choose to use, seems to be about 10 million. The official government auditing body, their estimate was about 10 million people will lose, or I shouldn't say lose, well, however you want to define it, will be ineligible for Medicaid. So that's what we're looking at. If you take, I don't know how to translate that into the SUD population, because the SUD population has a higher than average enrollment in Medicaid,
Right.
And it pays for like 70-80% of the SUD services we see in this country. So it's tough to say, it's tough to nail down how many people by state, a state like California, if they will be disproportionately affected. The SUD population, it's really tough to say. We need more time to analyze this data. And of course, finally, for a state like California, their concern would be undocumented individuals also losing coverage as laid out in the bill. The other concern that we have is not in necessarily enrollment, But the other aspect of the bill that's going to have a ripple effect is what's called a change in the provider tax. And again, without getting into a black hole of policy, and taxes, not my thing, it's not my policy. The simplest explanation is this. In the ACA, states were able to fund their Medicaid coffers through a tax on providers that the money went into the state coffers to fund Medicaid. And I think that was as high as 6.5% or 7%. That's going to be cut almost in half. The new cap will be, I think, about 3.5%. States are going to lose revenue for their Medicaid coffers. End of story. That's the real challenge, because while everyone's talking about eligibility, there may be ways, in a perfect world, we can fix that. We can get defined as medically frail. We can do what we can to make sure people are enrolled. We can do what we can to make sure they're maintaining their work requirements, or at least looking for work or engaging in the community. There are ways to do that. There's no way around this. And if you watch the news and you heard senators from rural states who said, we're concerned about rural hospitals, that's what they're talking about, this provider tax. States will have less revenue available to fund Medicaid, and that will almost certainly have a ripple effect on all services, and SUD potentially more than any other, and here's why. That is when states are going to be forced to make tough decisions on what they can cover. And they really only have two ways to do it: drop reimbursement rates on what they cover, or eliminate what they cover. So you can shave off a little off the top across the board, or you could just say, this is not covered anymore. And you and I both know SUD doesn't necessarily fare well when every program's put on the table and states start to say, what should we keep? What should we cut? Child health is going to be at the top, deservedly so. I'm not against that. Diabetes is going to be near the top. They're going to keep those services, elder care, what have you. We all know what the pecking order is, and we all know that SUD is not near the top. Even though we have made great progress, 20 years ago, we were nowhere to be seen. It'd be like, sure, you're done. Now
there still is tremendous stigma,
and advocates. But like, if there are people listening to this podcast who are thinking, well, what can I do? My advice is start talking to the people in your state who make Medicaid policy. Get ahead of this, because as you said, we're already starting to see. I don't know. I haven't heard of any necessarily closures, although I see some in the news from either hospitals or treatment centers or what have you. But it's going to start just even though this particular policy doesn't go into effect until 2028. States are already saying, we don't, state policies don't go day to day. They don't wake up in the morning and say you're funded and the next day say you're not. They have to plan for many years out. And that's where we're starting to see some real, heartbeats elevating in terms of, will there be money available for the services we provide? And we've already heard in Washington many senators and members of Congress say, oh, we're going to fix that. I voted for this bill because I liked a lot of it, but I didn't like that part. But we have time to fix that. If that's true, we'll see. But that's a really concerning aspect of it, because that impacts services across the board.
Absolutely. I mean, I think, in just to comment on that briefly, I think this is where, and to your point, rural states or rural communities, may be particularly hard hit. When it comes to states, there's going to be inequity and inequality, just because some states will be able to, foot the bill for these services and some won't. And Massachusetts, where I happen to be, is one of those states. I think recently, there was some discussion about the state trying to step up, and fill those gaps, potentially. And in that same discussion, that may not be the case for all states that just don't have the revenue to spread around.
No, you're absolutely right. It's what really gets me is, from just a logic standpoint or a data standpoint, not that logic and data make policy. They should. They don't. Take a state like Kentucky. When Kentucky expanded Medicaid, we saw a 600% increase in SUD services over a course of, I think, 12 to 18 months, something like that. It was insane. And that number, I'm pretty sure that number is accurate. I don't know over what time period, but I know we saw a 600% increase. So it's working, and now that is a lot of that is at risk. The irony is, I've gotten questions from states who have not expanded and said, I think there's still 7 or 8 states who have not undergone expansion, have said, how does it impact us? And I'm like, actually, for the first time since the ACA was born, you're actually kind of lucky. There's no changes if you don't have an expansion population.
Right.
Business as usual for you. Take a state, but here's another, and I don't know, I can't speak to every state, but I'm sure databases are being compiled. I do a lot of work for North Carolina. North Carolina just passed expansion last year. Or 2 years ago, very recently. And they have something called a trigger clause, and many states do. And the trigger clause specifically states if the federal match or the federal funds that come to us to assist us with Medicaid drop, that's it for expansion. And normally that applies to something called FMAP. It's the federal match. I'm not going to get into it. And they didn't touch FMAP this time around. But the question becomes, do these policies, they're not saying you can't have as much money in the formula, but you are going to have less people on the rolls, so you're going to get less money. Does that trigger the trigger clause? We don't know. There's still a lot to be determined. We still don't know more than we do know because it has to be implemented. And as our conversation continues today, I'm sorry, but that's going to be a recurring theme. A lot in Washington right now is we don't know more than we do know just by the nature of this administration and the way they do business.
Sure. Yeah. And I'll let you continue. I wanted to make one brief comment because I think it has to do with uncertainty, and it also has to do with the real world impacts. And, it has been tough, but I found some examples, of programs that actually are directly impacted closing or, will not, proceed as planned, because of these cuts. And, you do find them in a variety of states. Some of them are rural hospitals. Some of them are behavioral healthcare providers. It's throughout even, certain programs for the treatment of neurodiversity and other things. Part of it is the inability to hire. So there are policies being put in place that because we don't know, if we'll be reimbursed or what the reimbursement rates will be, there's a hiring freeze. And again, we have, very high rates of attrition and turnover, in the field. And so you have a lack of providers. There are lots of people doing, more care with less resource, those sorts of things. But it seems to be happening. We also talked with, for example, a recovery residence provider, who receives a cease and desist order, and that's happening, I think, around the country. Peer support recovery, services have been cut, things like that. So there do seem to be some, direct impacts even so far.
Yeah. Yeah, it's unfortunate. And again, between executive orders and funding questions, I guess we can continue to talk about that, but it remains to be seen what the full extent of the, for lack of a better term, damage will be.
Okay. Yeah. Right. So what about on the the SAMHSA front?
Yeah.
And the original proposed cuts.
Yeah. So let's talk about that. And let me recap for either new viewers or it has been a while. So, the way the federal budget process works in 2 sentences is the president proposes a budget. Congress then takes it upon themselves to propose their budgets, one in each chamber, one in the House, one in the Senate, and some kind of agreement is usually reached. Sometimes that agreement is a continuing resolution, which keeps last year's funding like we're in right now. But that's basically it. That's the process. And the president's proposal was a shock to the system for many advocates across public health because it proposed 2 things. It proposed drastic cuts across the board, and it proposed a reorganization of the Department of Health and Human Services. And within that proposal was a new entity, the Administration for a Healthy America, which would consist of SAMHSA, HRSA, National Institute of Occupational Safety and Health, parts of the CDC, on and on and on, and fold them into one administration in order to be supposedly more efficient and cut costs. One of those divisions would be behavioral health. The Congress, in an appropriations bill, if you were to follow the letter of the law, would have great difficulty doing this, because if you were to create a new entity within the Health and Human Services and you were to undo other entities, you would have to go through a process called authorization, which is a completely different process. So it was a double whammy for those of us who work on appropriations. One, what can we do about the funding levels? Two, would this reorganization actually happen? So usually the House does their appropriations bills first, and we were expecting the House to act in late July before recess. And then about a week before their committee was scheduled to produce their bill, the subcommittee chair, Mr. Aderholt, said, we're going to put this off until September. We were expecting the Senate already to put it off until September, and all of a sudden they announced, we're going to get this out at the end of July, taking everyone by surprise. We being advocates, spent several months talking to the House and Senate saying, we just can't get on board with this. There's too much. There was not enough. First of all, we like SAMHSA the way it is. Second, there was just not enough detail in the proposal for that we thought to go forward. The Senate tended to agree with us. I just want to add one more thing. It wasn't just a reorganization. Within this reorganization, what was proposed was taking the three major grants at SAMHSA, substance use, mental health, state opioid response, which total about $5 billion, folding them into one grant, one behavioral health grant, and going out to the states to be funded at $4.5 billion. So it's also, in addition to not being able to target certain things, it was a $500 million loss, or 11%, something around that, 10, 11%. Also, in substance use disorders alone, in the Center for Substance Abuse Treatment alone, they proposed getting rid of almost every program of regional and national significance, which would total about $800 million. And their rationale was that these programs were duplicative of the block grant. First of all, no, they're not. Okay, the block grant is statutory. It is in statute, it is in law what the block grant can fund and what it cannot. Its main purpose is to fill in the gaps that Medicaid can't fill, but there are limits on what that money can be spent on. Same goes for the mental health block grant. State opioid response grant, I would have to say, not as many limitations, and states have used it in more creative ways for the betterment of their states and for treatment and recovery, I might add. So these programs of regional and national significance, the reason they exist is because block grants go to the state. These programs of regional and national significance, they can go to counties, they can go to cities, municipalities, nonprofits. They could go and do specific needs for specific communities. For example, one is for neonatal women going through neonatal care who need treatment. One is for first responders for naloxone. One is for building communities of recovery, which is for RCOs, recovery community organizations. One is for treatment of homeless populations, on and on and on. And so we were looking at over $1 billion worth of money at stake. At the end of the day, the Senate produced a bill that looked very much like last year's bill. It funded SAMHSA as SAMHSA was funded. It funded HRSA as HRSA was funded. It funded CDC as CDC was funded. If you were to look at this bill, you would not know the president's recommendations for reorganization existed. Administration for Healthy America never came up in the bill. That was a welcome sight. That does not mean we are done by any stretch. There's a long way to go. And let me tell you the two things that we're keeping an eye on. One will be the House. The House politically has been more in line with the president than the Senate. Not necessarily on spending bills, because we've seen the House in their other appropriations bills, we've seen them do things that weren't in the president's budget, But the question is, will it look like the Senate bill, or will it look like the president's budget? Will it look like a mishmash? Either way, at least we have this Senate bill that anchors us in, we want to fund SAMHSA, we want to fund HRSA. At least we have one. So as people have said to me, well, is that good news? My answer has been, well, it's not bad news. Because if the Senate bill gave a green light to the reorganization, I don't think we'd have a chance. I think that would be it. So at least we have one bill. So at the very least, even if the House goes along with the reorganization in their bill, the House and Senate will have to come to some kind of agreement. Now, can the Senate say, hey, House, we like your bill better and go with that. They could. That's why this isn't over yet.
Okay.
If the House bill doesn't address the reorganization, does that mean it's over? No, it only means it's over for this fiscal year as far as Congress is concerned. Let me just add a few caveats to the situation we're in. So I've addressed the House and I've addressed the Senate, okay? And I've only addressed the appropriations process. And I want to be very clear. In talking to members of Congress, especially on the Republican side, because that's the president's party and they have the majority, so most of my time is spent with Republican offices, I did not get a lot of them saying this reorganization is a bad idea, okay? I got a lot of, we're not going to do this in an appropriations bill. So come next Congress or come next session in January, they may try it through the authorization process. We don't know. They may not. They may think it's a political loser. Elections are coming up. They may think it's a political winner with elections. We don't know. We're back to that theme.
Sure.
But at the very least, we have one bill that passed committee, not the full body, but passed committee, that at least we can use that as an anchor in some ways.
Mm-hmm.
Okay, now we come to the administration. We both know, it's no secret to anyone who watches the news or follows politics in the slightest, this administration is not very big on deferring to anybody. They kind of do what they want to do. The legalities of that, the constitutionality of that, conversation for another time. I will take off my SUD advocate's hat, put on my constitutional lawyer hat, have a different conversation. We're not going to talk about that now. This White House has already demonstrated that their goal is to spend money as they see fit, and we are wondering what that holds in store for next fiscal year. We have already seen them hold back funds that were duly appropriated by Congress for this fiscal year in 2025, not necessarily at SAMHSA, but at other agencies. I have colleagues who work with the CDC and the NIH, and those agencies have had real problems with money getting out the door, even though it was duly appropriated. The same day that the Senate passed their bill, the president issued an executive order on grant making, which, to summarize in one or two sentences, again, because we don't have that much time, the way grant making exists now is there are program officers at SAMHSA who oversee this, and there are division directors. And we said, we've got these programs, we're going to put these grants out for application. We get the applications, we grade them, we score them, we award the grants. What the president wants is for the head of each agency, who's a political appointee, to have a point person at each agency to review all grant making, to see if it is in line with White House priorities. What does this mean for SAMHSA? Well, it's a much bigger problem for NIH and CDC because they're bigger agencies. The one piece of not bad news is that this order will not apply to block grants. Okay, so that $5 billion at SAMHSA of those three grants I mentioned, if you take SOR, State Opioid Response, and define it as a block grant, which in a sense it is, that's not going to be touched. So the question becomes this. I have several questions from a substantive standpoint and a procedural standpoint. Again, I am an attorney, and that's how my brain breaks down every problem. Substantive, procedural. The procedural, let's do the procedural question first. Right now, there are no political appointees at SAMHSA. I think if SAMHSA were fully staffed, there would be a grand total of 2 political appointees. The administrator, who's the deputy secretary for behavioral health, who has not been appointed, and a second political appointee to, advance White House policies at the agency. Neither one has been appointed. There is one person at SAMHSA right now who kind of reports to the White House, who is the deputy, I believe his title is deputy director, but it's not a Senate confirmed position. The Senate confirmed director has not been appointed. So the question
is that normal? I'm sorry. Is that in your experience? I mean, is that typically the case?
In my experience, if it were like June and we still didn't have a SAMHSA administrator, I'd be like, I've seen that before, because I have, it's August, and the question becomes, have they, A, just not gotten around to it yet, which is possible, or B, do they plan to go forward with this reorganization and say, we're not going to need a SAMHSA administrator. We're going to have this, who knows? Again, unknown greater than the known. So let me just talk about the procedural issue. Without those appointees, does that mean all grants just freeze? They just, the machinery stops without this review process? Or does it mean that the person currently in SAMHSA who reports to the White House, who was set there to, run the agency while it is in this limbo, do we keep up business as usual? Does everything stop because there are no political appointees? We're waiting to see. Second, substantive. What are they looking for? And that kind of forks out into two branches. We all know what this administration has been looking for to this point when it comes to grants out of HHS that they want to, stop from going out. And that's usually things that have to do with DEI, LGBTQ community, and a few other social things here and there. The question becomes, is that what they're looking for in terms of policies? Or are they going to just put the brakes on all those programs that they wanted to eliminate in the budget proposal? That's my question. If you read it in the context of what we've seen so far, it's the first. They're looking for things that aren't in line with this White House's general zeitgeist or whatever word you want to use, aura, sure, or their message, building communities of recovery, neonatal care, naloxone, those don't, Next question, are they going to look at every single aspect of every grant, down to the last dime? Or is it going to be a general, we'll read the description that we got in the application, the award, and we'll go based on that? Again, unknown. So the future is really, really almost, the crystal ball is, useless. Yeah, I would say the crystal ball's cloudy, but cloud's clear. Crystal ball's useless. We really don't have any idea as it pertains to, and maybe this will be a good segue to our next subject of discussion. When it comes to SAMHSA itself, the White House has already been clear on what they don't want to see. Obviously, things like DEI, things like LGBTQ, they've been clear that's across the board. They don't want to see it. An executive order was issued about 2 or 3 weeks ago. And the main subject was homelessness. And we can talk about this more or not. It's up to you. But what impacts SAMHSA and HRSA and other grants is pretty much putting the kibosh on anything having to do with harm reduction that's not naloxone. So that would be, syringe exchange, safe injection. There aren't many safe injection sites, obviously. On Point, New York is the one people talk about. To my knowledge, it hasn't closed yet. But obviously, and that this is not big news to anyone who follows Trump policies. It's very clear where he comes from politically on SUD. He's very much a war on drugs type. He said last week, and there was an article in the New York Times last week about him wanting to go after the cartels with military force. He's very much a supply side guy. So we're not, we're not surprised. On the other hand, SAMHSA does not currently have many grants that say this is for harm reduction. We did have one from FY 22 through 24 at $10 million a year, and it was funded through the Biden's COVID recovery plan. It was, it was not renewed, I think, in FY 25, so it hasn't existed for a couple of years. Other than that, there are not many SAMHSA programs that fund things like syringe exchange, or safe injection. Now, when you get downstream, do some states use state opioid response money for those types of programs? They might. I don't know. Again, it's hard to account for every dime because once the money goes out to the states, it's in their coffers and the money's distributed as state funds. Right. You don't get funds and, with a note that said this is from the block grant. If you're in California, you get the money from Sacramento and that's it. So that's how the block grants and the SOR grants work. So the big question as an advocate that I want answered is this how's it going to move forward? Are they going to look at every word with a fine tooth comb, or is it just going to be another layer of, are things just going to slow down? But yeah, it's the courts, as we have seen, have many times said you don't have the power to do this, whether it's with NIH grants or with other
Right.
things. But
And there was an injunction in May, I think, something like this,
yeah,
that, for those black, right. I don't know if that's
but this White House, it's been well documented that this White House has been acting in defiance of the courts. And again, that's a conversation with constitutional scholars. As a SUD treatment and recovery advocate.
Yeah.
Yeah. So.
And I guess given all this, I mean, one thing I did want to ask, briefly, and then I wanted to, maybe kind of close out with something. And this is always, it's so fascinating to hear your perspective. I don't think there are really many people that have that perspective. And it sheds a tremendous amount of light on what is actually happening. And, the uncertainty is absolutely incredible, and it makes it very, very difficult to plan. I mean, a question I have, and again, I don't want to get, too much into the, it is political, but, probably, but there seems to be, there is bipartisanship across the board, it seems, in terms of support. I mean, it's not as though this is a one-sided equation. Even in the, recent Politico article that was talking about, potentially a a second reconciliation package that might, have implications for Medicaid spending and even, I think, Medicare spending. It was noted, that there are many people on both sides of the aisle, that oppose that. There are Republicans that, are concerned about their states and they want an effective Medicaid and Medicare policy. So, I mean, is that your finding? I mean,
when it comes to rhetoric, you can say anything in Washington. You can say this is a bipartisan issue. That doesn't make it so. Sometimes it is, sometimes it isn't. I've been doing this a while. I've been working on appropriations for 24 years. I've been in Washington for 30. And I have always been of the opinion, if it's not about the money, if you don't have the money to execute your policy goals, what are we talking about? Yeah, there are two kinds of legislation we work on in Washington: funding and regulatory. The regulatory side is not really, especially in I would say for the last 6 months, I've spent a couple of hours on some regulatory stuff. The rest has been spending. Both sides of the aisle will agree with me on this. Hal Rogers of Kentucky, a great ally of SUD, once said, "A vision without funding is a hallucination." I once heard a senator from Delaware by the name of Joe Biden say, "Don't tell me what your priorities are. Show me your budget, and I will tell you what your priorities are." It comes down to funding. So both sides, and this is not a Democrat, I have encountered both Democrats and Republicans who will say to me, well, this is a bipartisan issue. And then when it comes time to step up and get the funding that we need, they're not necessarily anywhere to be found. There are others on both sides of the aisle who are. I don't want to name names,
sure.
But we could not have accomplished what we did in that Senate bill without some great Republican offices helping us out. I should say their names to give them the praise they deserve, but I want to save some secret sauce from my business. But anyone who thinks that because I like this side or I like this, both sides have stepped up and both sides at times have not. So it is bipartisan when it comes to the talk, but as the author James Baldwin once said, so we can get outside political quotes and get to quotes more about the human race. James Baldwin, one of my favorite quotes of all time: "I cannot believe what you say because I see what you do." If you're a member of Congress looking me in the eye and saying, "Oh, this is a bipartisan issue," and I know for a fact you voted against increased funding for these programs, I know you're not on my side. It's very easy to say things to reporters, to the cameras, what do you do? And this has come up a lot for advocates in the sense that as we talk about SAMHSA and other programs, and here's the thing about SUD, there are SUD programs outside SAMHSA that actually have more money than SAMHSA does. Starting at the VA. VA spends more money on SUD than any other agency. There's programs at HUD for recovery housing. There's programs at labor for people reentering the workforce. There's program, yeah, on and on and on,
Hmm.
So we're not a one-trick pony in that regard. You will find many, many members of Congress who both say and do things to make you think, yeah, SUD is a bipartisan issue and I can find support on both sides for people who care about it. I'm going to be brutally honest here. When you talk about SAMHSA as an agency, it's harder to find people to step up because it's small
Hmm.
and it doesn't spread around the money like in NIH or Veterans Affairs.
Okay.
NIH spreads, has 40 something billion dollars in grants. SAMHSA's
Hmm.
got 7 at most, so it's just
Right.
not as it's members of Congress have many, many agencies and many areas that they talk about, and you're not just competing with other health issues to get to the fore, you're competing with all issues.
Hmm.
So is it bipartisan in the sense we have support from both sides? Yes, but that doesn't mean you go to the front of the line because you're still competing with other interests, and it's very hard to get attention for, only in Washington can we say this, $7 billion for a small agency.
Sure.
It's tough to get that attention. And if you were to go to the average person on the street and interview and say, what does VA mean? More people are going to say Veterans Administration and know that than if you were to say, what does SAMHSA mean? And they say, oh, Substance Abuse Mental Health Services Administration. I know congressional staff who don't know what the acronym SAMHSA means.
Sure.
It's, we're still in a position of being, as far as we've come, as I like to say, if you fell down a 100-foot well and you've climbed up 40 feet, you could look back and say, wow, I've made some great progress. If you look up, there's a long, long way to go.
Right, for sure. Well, this kind of leads me to, I wanted to end on a slightly, tangential, but I think important, area. And it's really the idea of fatigue, in behavioral health, really healthcare generally, but behavioral health particularly. It could be
I thought you were talking
care.
about my third cup of coffee.
No, that's different. That's totally different. And I think, coffee's supposed to be good for you. But there's a huge lack of treatment providers. There's a paucity of clinicians. So, across the behavioral healthcare spectrum, I've heard it reported that we need something like perhaps 400,000 additional providers, to fill the need. And the other part of that, part of the reason is turnover is very, very high. These are very difficult and challenging jobs in many cases. I think in some cases you have turnover rates where, people are changing jobs in a year and a half, something like this. And there's a tremendous amount of burnout, among clinicians. And I wonder if do we also see that on say your side of this equation, the people who are, thinking about policy and advocating? I mean, how is it over there?
Yeah, we do. It's something new every day. I actually was having a conversation with a colleague last week. I called her when the executive order I mentioned on grant making came out. It came out Thursday at like 4 or 5 o'clock, and I called a colleague the next morning at Friday at about 9:30 and said, hey, what are you hearing about this order? She goes, oh, you mean the one about the cartels? Because that was Friday morning. And I was like, what cartels? I'm talking about the grant. She's like, oh, no, I'm talking about the one that came out this morning. So it's like,
wow,
it's whiplash. It's like, you call it what you want, call it whiplash, call it an avalanche. The answer is yes. I could say yes. Next question. But instead I'll quote The Simpsons because the opportunity presents itself and you never pass up an opportunity to quote The Simpsons. The Simpsons and Star Wars. Never pass up an opportunity.
For sure.
Reverend Lovejoy, in his answer to Ned Flanders once said, long answer, yes, with an if, short answer, no, with a but. So I could go long answer or short answer. I mean, the short answer is, it's hard to keep up because not only have we never seen policies like this before on the procedural side with the grants and the not spending of funds and the extreme limits that this White House is trying to stretch the government to. We're just, it's just something is coming out at us every day. And some people say, well, that's the plan. That's the their political motivation is to bury you under so much stuff, cause like, I mean, I've been reading about, advocates who every time something from the White House comes out that if the advocates think may not be legal, they file a lawsuit. Most of these lawsuits are filed by states' attorney generals. How many lawsuits can you file? So that's not me. I'm not on any lawsuits. If anyone from the White House is watching, I'm not on any of those lawsuits. But I use that as an example. It's also, as I said before, we have been under so much water on spending issues between reconciliation and appropriations. We have had so much to deal with. We haven't had time to work on the changes we need to make from a regulatory standpoint to do the things we need to do to help our workforce and our consumers as easy. So the workforce is burned out. The consumers are burning out because they can't get the services. We want to help them with how do you do that? Legislation and funding. Yet Congress itself, I mean, if you were to read the news and think that the news covered every piece of legislation, I mean, what has Congress done besides reconciliation, this year? Not much. And they went from reconciliation to the spending bills. Like yeah, they passed bills here and there, but the stuff I work on, and this has been happening for a while in Washington, the do nothing Congress has been, unfortunately, each year less and less gets done. But the ability to see things move, especially in 2025 with reconciliation taking up so much oxygen, it's a, burnout is a really strong word. And I don't want to concede to being burned out because I'm still here, still doing my job. My colleagues are still there, still doing their jobs. But we definitely feel overwhelmed. And we definitely, on any given day, I can look at 7 or 8 fires and pick one to try and put out. I guess what it comes down to is I've always said advocacy and SUD recovery are born of the same mother. Like, what can I control?
Right. Right.
I myself am not in recovery, but I know many people who are, and I work with many people who are. And one of the first things I always talk about, what is in my control? So when I see things about like reviewing grants, what's in my control? I can't change what the White House wants to do, but I can find out as much as I can about it and get it to my people who I work with so they are as prepared as possible. I have always said people like me in Washington, number one job, traffic cop. People think that, the position I hold, who do what I do, we go into congressional offices, we say, hey, write this bill. It's a good idea. And the bill's written and it's passed or not passing on to the next one. No. Most of my time is spent taking what goes on Capitol Hill and breaking it down into a language that people I represent can understand so they can say, well, this is good, this is bad, we support it, we don't, and them saying to me, here's what's going on in the field, here's what we really need. Me going back to Congress and saying, hey, that bill you're working on, what we really need is this. How about it? So it's a back and forth, and I'm just standing there in the middle. As more and more information comes out from this White House, more and more executive orders, more and more, decisions on spending, there's more traffic. Right. So, that's why I use the term whiplash, because you're just, so, and everyone wants to know everything about, of course, everyone, rightfully so, if I represent you, you want me to do my job, and they say, how does this affect us? And I have to say, gotta give me, a little times. Are we burned out? No, we're not burned out. Would we appreciate being cut some slack? Yeah, we'd love to be cut some slack and just give us some time to figure things out, maybe a little bit longer than usual.
Absolutely. And I think that goes, again, it's on all sides of this equation,
yes.
So that feeling.
And we're not alone. And, we're not alone in healthcare, in HHS, and we're not alone across the federal government. And, but I will say this, when I say not, I've mentioned NIH and CDC a few times. And you mentioned the bipartisanship of SUD. If there's one thing I can cling to, and I'm not proud of having to cling to this, I think it's clear to everybody that the HHS agencies that are in the crosshairs of this administration are CDC and NIH. And it's because of 2 things. One, this political fallout of the COVID pandemic as I have to say, as ridiculous as it is, they blame the CDC and the NIH for that. And NIH is, like I said, a $44 billion, $45 billion agency. If you're a fiscal hawk and you want to cut, you go to where the most money is, and that's NIH. So my friends who do more work I do some work on the NIH side, National Institute of Drug Abuse, National Institute of Alcohol Abuse and Alcoholism, so and so and so. But these policies, these executive orders, I really sense they're aimed at those institutes, and SAMHSA is collateral damage. If at the end of the day, they choose to go the route of holding back funding for all those programs I mentioned before, then we've got obviously a big problem. But the sense I get is that, like you said, we're still a bipartisan issue. SUD, even though Trump may have a different approach than Biden or Obama, it's still kind of bipartisan. And it's still something that you're like, look, we got elections coming up. We don't want our opponents saying you cut funding for this when overdoses are still quite a big problem. That's not if you say you cut it for NIH research and you pick some grant out of the hat that sounds ridiculous on its face because you don't understand the science, that's a political winner for some people. Putting funding for overdose, that's, I remember the last midterm election that happened during the Trump administration, and we'll end on this. In 2018, when members of Congress had to go home and run on their records, and the Republicans knew that they might be in trouble because it was an off-year midterm election, I saw over 75 pieces of legislation introduced on overdose prevention and treatment because they knew it played well back home. Now, we're not in that environment because the opioid epidemic, numbers have come down, but it's still a pretty big problem. And it's still they knew this was a good issue to run on. Are we in a different environment? Yes. Does the issue of Trump's larger influence on the political sphere weigh heavier? Yes. But we've still got that tiny foothold of, we're not really who they're after. And as I said, that may not be good news, but it's not bad news. And that's the best we can do right now.
Yeah, absolutely. I think that's a good place to wrap it up with the exception of, we usually say, what do we look for next? Is there anything to look for next?
Well, that's an easy answer. I'm going to look for the House Appropriations bill, hopefully for second week of September. And again, that's do they go in the same direction as the Senate? Do they follow the White House? I don't want to get into what I'm hearing in terms of rumor and conjecture. But we know the levels will be less than the Senate bill. We know that the level. Will the structure be different from the Senate bill? If it's not, and they keep the same structure as the Senate bill, then we can say, okay, at least we're done with that, and we can focus on the administration and what they plan to do with their proposed reorganization and the grants and whatnot. If they go along with the president, it creates a different dynamic. So that's what we're going to look for. Okay. And then there has been rumblings about a second reconciliation bill. But as you said, can they pull that off? Do they have time to pull it off? And what's left to tinker with when it comes to Medicaid? The next thing left to tinker with is FMAP, which is a federal matching rate. And if you thought the last time was a political knockdown, drag out fight, this would make it look like a lunchroom, a cafeteria flat fight, so.
Wow. Okay. All right. Well, as always, thank you so much for helping us understand this incredibly complex issue. The stakes are very high. So
I have a feeling that I'll be back maybe in November or December for like a year-end wrap-up, which most certainly will be.
For sure. I'll look forward to that. Absolutely. Yeah. So Andrew, thank you so much. Really appreciate it.